background medications were digoxin and diuretics, and there was a heart failure recurrence after withdrawal of metoprolol in 9 out of 15 patients. Their ejection fraction dropped from 46 down to 35, which was statistically significant after 72 days, and there was also a rise in heart rate. And in this study, there was 1 sudden death on metoprolol withdrawal. This was a later study by Wagstein in 1989, which looked at 24 patients. These had stable heart failure, functional class improvement, NYHA 3.3 to 1.8. Now, this is a really lovely graph. This is looking at NYHA class. This is on chronic metoprolol treatment, and you can see that there are generally improvements in the NYHA class. On metoprolol withdrawal, there are deteriorations in NYHA class, and 16 deteriorated over a 12-month period, which included 4 deaths. After re-administration, there was improvement of the NYHA class, and 8 remained stable for a period of 2.5 to 6 years. The ejection fraction in this study was also significant, dropped from 41 down to 32 on metoprolol withdrawal. This was the third study, which came later in 1999. They looked at 13 patients who were stable on metoprolol for 30 months, and then they withdrew metoprolol in a stepwise fashion over a 4-month period. So we can see here again, this is the ejection fraction improved on metoprolol, worse after cessation, heart rate decreased on metoprolol and up, and also premature ventricular contractions. 4 died out of the 13 from this study. So very clearly, beta blocker withdrawal is a no-go zone. Digoxin withdrawal, these were the studies that Pim talked about earlier. So there are 2 studies of digoxin withdrawal, the PROVE study and the RADIANT study. So this was done in heart failure patients with class 2 to 3, sinus rhythm and background ACE inhibitor sorry, that's not right. So PROVE had diuretics and digoxin as a background, and RADIANT had diuretics, digoxin and ACE inhibitor. So they came in on the trial and they're digoxin and diuretic plus or minus ACE, and then were randomised to placebo and diuretic or digoxin and diuretic. So this is the PROVE trial. It was published in 1993, the 88 patients. This is change in maximal exercise time, and with digoxin there was no change, and the maximal exercise time reduced with placebo, and the time to treatment failure was significantly reduced in placebo. This is the RADIANT with the background ACE inhibitor, same measures, change in exercise tolerance, reduced with placebo, and the time to treatment failure significantly different. A third study of, an indirect study of digoxin withdrawal was the DIDGE trial. So this was a post hoc analysis of the DIDGE trial. So 3,365 patients came into the trial on digoxin. Of those, 1,600 continued on digoxin and 1,700 were discontinued. And this is looking at the outcomes. This is the article presented it in an interesting way. They broke off, so this is looking at all-cause mortality, and they broke up the groups into low serum digoxin and high serum digoxin. So placebo's in the middle, and they found for all-cause mortality that the lower serum digoxin concentration did better than the higher, so hence the recommendation that we now use serum digoxin levels of under 1. But heart failure hospitalisation, placebo group here, and there was a reduction in both groups. But however, there was no effect on all-cause mortality if you look at the groups together, and an increase in all-cause hospitalisation. So that led us to then go and review all of the trials on digoxin withdrawal, and there were 7 studies, including 3,000 patients. So this is looking at all-cause mortality, and there was no change in all-cause mortality, and when the DIDGE trial was removed, the result was the same. There's a rise in heart failure hospitalisations, and again, when the DIDGE trial was removed, there was no change in that result. There were 5 studies that demonstrated an increase in heart rate on digoxin withdrawal, statistically significant, and a fall in systolic blood pressure. And there were only 3 studies that looked at change in left ventricular ejection fraction by echo, and these are all quite old studies, and there was no change in this at all. All of these studies, however, were done prior to beta blockers, and given that there's similar pharmacodynamic actions of beta blockers as digoxin in many ways, we don't know what's going to happen in this scenario of full neurohormonal blockade. So the next study I want to discuss is whether dose reduction is possible. This was a study done by De Silva, published in 2007, and it was in the context of patients with renal failure. So 68 patients had heart failure and renal dysfunction with a serum creatinine greater than 130. And they ran them through this algorithm to reduce or alter heart failure medications. So aspirin was switched to clopidogrel, diuretic and ACE inhibitor doses were halved. There was a change from bisoprolol to carvedilol, and overall this intervention resulted in an improvement in serum creatinine of 35 micromoles per litre. ACE inhibitor reduction was well tolerated by 68 patients, and they had no increase in symptoms over the next 4-week period. Diuretic reduction, however, was not well tolerated. 7 out of 18 failed discontinuation, and 18 out of 50 failed cessation. So diuretics are known to stimulate the renin-angiotensin-aldosterone system, and they also worsen renal function in the short term. So this is a list of all the studies of diuretic withdrawal. So there are 7 of them. These early ones are very interesting because they were done in the development phase of ACE inhibitors. And what the question they were asking was, can we replace diuretics with ACE inhibitors? And so these ones, diuretics were stopped, captopril started, or diuretics stopped, lisinopril placebo, or captopril placebo was started. And there were quite significant failure rates associated with diuretic withdrawal. And these later studies are just pure diuretic withdrawal. So that's just to demonstrate. There are some successful studies, 70% went okay there, but overall, it's not completely safe. So this was the study by Galv. It was published in 2005, and it actually looked at the effects of a diuretic withdrawal. So it was 26 patients, ejection fraction 34%, so on ACE inhibitors but not beta blockers. And they had diuretics withdrawal, and they demonstrated that there was better renal function, so an improvement in urea and creatinine, an improvement in glucose control, so 151 down to 121, an improvement in diastolic, a rise in diastolic blood pressure, a drop in plasma renin activity, statistically significant, and also a rise in ANP. There were no studies on spironolactone withdrawal, and a lot of the more recent medications haven't been looked at. So the next issue is recovered ejection fraction. So lots of patients are now starting to have this condition. So this was a study from Panus, which was in the Journal of Cardiac Failure in 2011, which looked at sequential patients who presented to heart failure clinics and documented the type of heart failure that they had. So they found that most patients had heart failure with reduced ejection fraction. There were some with HFpEF, but it was a big group who had recovered ejection fraction. And these patients, as you probably all know, are younger. They have less comorbidity, so less atrial fibrillation, less hypertension, less diabetes. They're less likely to be ischemic than the HFrEF. They have better renal function, and they have better LV diastolic dimensions. So there's not much around about this group. However, a study, which was a retrospective study by Moon in 2011, looked at idiopathic dilated cardiomyopathy patients who had been stabilised on optimal treatment with beta blockers and ACE inhibitor. And there were 42 patients who had recovered their ejection fraction for an overall mean of 26, up to 56% over 41 months of follow-up. So that's their ejection fraction there. And we found, of these 42 patients, that there was a recurrence of heart failure in 8 patients. From the baseline characteristics, there were no predictors of what would cause recurrence. However, of those 8 patients, 5 had withdrawal of therapy. And so withdrawal of treatment resulted in an odds ratio of 26. And this is looking at LV function in those who had continued on their medications versus those who withdrew. So there's, of 32 patients in this cohort who continued their medications, only 2 deteriorated, and of the 7 who withdrew their medications, 5 deteriorated. So peripartum cardiomyopathy is the last group to discuss. There isn't very much information around on this at all, but Amos did a study in 2006, which was again a retrospective study. So it was 55 patients. 22 of these 55 patients had normalised their ejection fraction to greater than 50%. So overall, this is looking at the number, there was some patients were transplanted, some remained a low ejection fraction, and then a fair group improved their ejection fraction to greater than 15%. So of these 22 patients who had normalised their ejection fraction, 15 then went on to have further echo at 29 months, which showed no deterioration. And of those 15, 10 had stopped either their ACE inhibitor or beta blocker, and 5 had ceased both, suggesting that peripartum cardiomyopathy has a slightly different etiology, and that this group may tolerate withdrawal of medications better than others. So ancillary medications are commonly prescribed in heart failure, and really guidelines should be followed. So looking at aspirin and heart failure, for individuals with heart failure of ischemic etiology, antiplatelet therapy should be dictated by the underlying coronary artery disease, and for individuals with heart failure of non-ischemic etiology, routine use of antiplatelet agents is not recommended. In our clinic, it's very commonly used, and patients and doctors don't like giving it up. The other one that's very controversial is statins in heart failure. We all know about these studies which look at the outcome studies, the Corona and the GCHF, which showed that there was no benefit to giving statins in heart failure. However, again, in our clinic, people are very loath to give them up. There's a question of whether there's pleiotropic effects of statins that go beyond the reduction in coronary events. And this was a study by Henry Crum in 2007. It was called the Universe Trial, and it looked at the change in left ventricular ejection fraction assessed by radionuclide ventriculography. This was in idiopathic heart failure, and what it demonstrated was that there was actually more of an increase in ejection fraction with placebo than rosuvastatin, but non-statistically significant. So there looks to be no effect on ejection fraction from statins, and also there was no beneficial effect seen on neurohormones or cytokines. So in summary, in stable heart failure, ACE inhibitor and beta blocker should not be withdrawn. Diuretics should be used at a minimum dose. Dose reduction of some medications may be considered, and ancillary medications should be prescribed according to guidelines. In recovered ejection fraction, cessation of medications is associated with recurrence and cannot be recommended. And in peripartum cardiomyopathy, medication cessation can be considered if recovery has occurred. So that's cool. Thank you.
Thank you very much, Dr. Hopper, for this very interesting presentation. Who would like to ask a question? Yes, please. Professor Feitosa.
Congratulations. Would you have any comment about myocarditis, viral myocarditis patients? Occasionally we see transient, severe heart failure that later on will regress with normalization of left ventricular ejection fraction. And still you are very reluctant to discontinue the medications. Do you have any opinion on that?
I do. I think I would agree with you entirely. I think the severity of the heart failure, the risks of recurrence, it's unstudied, there's no evidence for it, but the potential of risks of recurrence of a severe myocarditis outweigh by far the benefit, the cost of staying on ACE inhibitors and beta blockers.
Yes, please.
Thank you very much. Cardiologists normally want to know about these patients until they reach a stage of end-stage heart failure. And after that, they don't want to know about it. They end up in a general medical ward. I'm a general physician. We tend to languish with these patients. The difficulty is, it is not difficult to increase or decrease or withdraw drugs or add drugs when they are responding, but when they reach a stage of end-stage heart failure, that's a difficult question. My question to you, do you have any information or experience with withdrawing drugs and constituting or replacing that with palliative care at that stage? And if there is any biomarkers or any clinical indicators as to when appropriate to do that?
Yeah, I don't have experience with that, and I don't think there's any literature around on that. But I think if, from a practical perspective, you're a clinician, you're palliating the patient, I think you've got to go for comfort measures. And if they hate being on their beta blocker, I would stop the beta blocker.
The most difficult part of this is to persuade relatives and the patient that they cease to benefit.
Yeah, I think the other problem with palliation in heart failure is palliation can take years as well. So I think you would be guided by what the patient wants. I think you would leave medications on if there's no problems with it, but if the patient wants to have them removed, doesn't like being on the beta blockers, renal function is deteriorating, it would be reasonable to consider dose reduction or stopping, but again, patient-led.
Thank you.
Professor Talwar first, and then Professor Yu in the back.
Very interesting talk. Just a comment that in your list of peripartum cardiomyopathy that we can withdraw, there's another entity, I think, like tachycardia-induced cardiomyopathy. Once you take care of the tachycardia, I think those are the patients which can be off the drugs.
Yeah, great. Thank you.
Very nice talk, CMU from Hong Kong. Can I ask you, with regard to acute heart failure, there's still some people trying to temporarily withhold or reduce the dose of beta blocker. What is your opinion on that?
Yeah, I'm not an expert in that particular area. However, my understanding, and you guys might be better to just talk on this than I am, my understanding is that patients do better if they remain on the beta blocker during the acute admission. Is that your understanding as well? Yeah.
If the patient does tolerate the dose, we try not to reduce it, but in some very sick patients, we just go for reduction and try to keep them on the beta blocker. Only in very, very sick patients is then that we do stop the beta blocker.
And would you then, after the patient stabilized, try to up it again? I mean, that has been always the old way of thinking, hasn't changed. Any more?
Regarding the tachycardia-induced myopathy, or one of the things that happens is you get a patient that really recovers, but I couldn't take them off the beta blocker because, just as you said, neither I nor the patient feel safe to stop the medication, although they had really recovered from the cardiomyopathy, but still a low dose of beta blocker made me feel safer and the patient also.
Treating the physician.
Very, very good reason to treat patients, I would say so.
We have not many, but I think two patients we recorded in the literature also, but they are now, for years, maybe one patient over 10 years. So I think because then the cardiomyopathy is related to the rate. Once you take care of that insult, I think probably it may not. But this question of feeling.
The last question over there at the back.
Okay, thank you. Thank you for this very interesting talk. I'm asking about peripartum cardiomyopathy. Are you going to stop breastfeeding and start on ACE inhibitor or any other option for this?
Breastfeeding for the mother who has a cardiomyopathy.
Breastfeeding?
Yeah.
I think I'd have to look up the guidelines for breastfeeding, but I think you'd have to keep the mother on the medications, and my understanding is they're class B, so there are some risks to the infant, but they're pretty low risks. But I'd have to look up what the recommendations are. But essentially, you'd have to treat the mother over the breastfeeding.